is concerned, I know it very well. Last year, 5,37,000 accidents, motor vehicle accidents, we had deaths on the roads in India. I have written to Noto, no answer. As usual, whenever I write, there is no reply. Now I am asking you, you were in Delhi. How many homographs you have done? How many homographs walls are there in this country? I'm asking you.
Well,
You know,
sir,
it is not as expensive as what they say. We started this homograph business in 1981. Myself and AP Chaukar, both of us were called by ICMR to start homographs, cryopreservation bank. Anyway, government always gets the support.
I know, sir, you have tried a lot and we are,
Yes, that is why I'm asking. If I had not tried, I will never talk. I will never.
because we did start this homograph valve bank, Dr. Sampath started at AIMS, and we were quite successful in that one. But as you said, it is very difficult to get the consent.
The Noto is giving consent. Soto is giving consent. What are you talking about consent? It is not about consent. I told you 5,37,000 good homographs
Yes, sir.
has been thrown away. Now, the other question, you are all doing homographs. Transplants. What happens to the recipient hearts? Do you use it?
We did use the recipient hearts.
No.
Native valves we have used, sir. Aortic valve, pulmonary valve, we used to harvest them.
Harvest them.
And we have used them. We have used them. But the only thing is that suppose we are using them as conduits. In that case, the length used to be small. For placing any RVPA conduit or
why
anything.
is that the length is small?
But valves we have used there. Valves we have used.
Valves.
Yes.
Why I am saying it? I can tell you, a girl who had a transplant 13 years ago, we used her both valves and we have got good follow-up. 13 years, both these people who had the homograft and the RV outflow, they are doing well. Now, don't talk about money. Don't talk about, it is a little tedious work.
Yes.
After doing a transplant, just, arranging a patient to do a immediate aortic valve replacement. That means you should have two patients. Because I'm talking about fresh antibiotic cell lines, not even antibiotics.
Those were the
fresh homograft that is being used.
Those were the best homographs to be used in the valve position.
Yeah, I know it. I know. We have been using homograph from 1976.
Yes, sir.
So you don't tell me all those. But my question, it is not to you. I'm asking all these surgeons here and saying that, they are doing that, this and that. Fine, very good. Technology has to improve. But at the same time, what is the longest follow-up? I can tell you, we have done a aortic homograph in a pediatric 4-month-old. That guy is 26 years old now. No aspirin, no, warfarin, nothing. If I had time, I got a slide with me. I'll show you the echo 26 years after when the boy had, one more factor I want to tell you. When he had aortic valve replacement, Ross, at the age of 4 months, we redid it at the age of 6 months. 6 years. And again we redid it, but it is for 26 years. He's doing well.
I agree with you.
Thank you, sir. I think that is the relevance of the next talk. If we repair valves, let's hear from Dr. Christain Brizard as to how do they fare in the longer term. So those comments were very pertinent, and so is the talk. I think we'll request Dr. Brizard for his next talk. Thank you, sir.
Where's my first slide? Okay, so the talk is very long. I have to go through a lot of slides. I will only do the left side. I don't have the time for the right side. And I won't talk about Epstein anomaly. I will talk about aortic valve, mitral valve, and redo left AV valve after AV septal defect repair. So the critical aortic stenosis, so stenotic or regurgitant bicuspid aortic valve in pediatric patient. The strategy at the Children's Hospital has not changed since Roger Me. You have to repair until you can do the valve replacement safely. When there was only mechanical valve replacement, it was adult age. Now with the Ross procedure, it is not significantly different in our view. We don't think that the Ross procedure can be done with a very nice long-term outcome in very young patient. On the top of that, since 2013, we have demonstrated formally with our statistics that the surgical valvotomy is far superior in terms of reoperation, freedom from reoperation than the balloon valvuloplasty in neonates and in young children. So the strategy for neonates, either critical aortic stenosis or aortic stenosis, would be a surgical valvotomy, plus or minus repair, including patches. And that would lead in an interval between several months to sometimes up to 10 years to a recurrent stenosis associated with regurgitation most of the time. If there is a small annulus and predominant stenosis that would lead for a Ross procedure. And we support the sinotubular junction with PDS mesh. If there is a large annulus, we would emphasize the repair, but you can also do a Ross procedure with a PDS mesh. If you have done a repair, you can do a re-repair. In children and teenagers with primary congenital aortic stenosis or regurgitation, sometimes after a balloon valvuloplasty several months or several years earlier, if there is a small annulus and predominant stenosis, Ross or repair. If you can repair it, is nice. If there is a large annulus, we would favorize a valve repair. So I had experience when I was in Paris of doing aortic valve repair with cusp augmentation, systematic 3 cusp augmentation in rheumatic patient. And I introduced that when I came into the Children's Hospital for bicuspid aortic valve, so tricuspidization with cusp extension, which with a very good initial result. But we demonstrated after 10 years that the freedom from reoperation in this valve repair was less than the one who had had no patches. So we moved to a tricuspidization when necessary only. That is when you cannot achieve a valve that allows for the requested dilator without an opening of the raphe. And so we now do the tricuspidization without cusp extension, but just with the creation of one commissure. And this is here with the cardiocell neo. But you can do this operation while preserving the bicuspid anatomy. And this is done here. It gives a bicuspid valve, which is very stable, a lot of native tissue and one native commissure. So these valves have very good long-term outcome. I'm sorry, I have to read because something is mixed. The aortic valve repair in children without the use of a patch. So all the publications are from our unit. It's not a review of the literature. It is our own results. So the freedom from reoperation when there is a reoperation, a aortic valve repair without the use of a patch, neonates and infants and older children. Freedom from replacement, neonates, and in blue, the patients that are older. So in children undergoing aortic valve repair, repair without patches is feasible in approximately 1/3 of the whole of our whole cohort. aortic valve repair without patches achieved with no operative mortality and survival of 95% at 15 years. Infants, old and older children, freedom from aortic valve replacement was 60% at 15 years. Neonates, freedom from aortic valve replacement was 53% at 15 years. And last, in that group of patients, the freedom from aortic valve replacement after a second repair is that one that is 50% at 15 years. There's lots of things that appear on my screen. Sorry, can you help me? There's lots of things that come on my screen. So there's a similar study with patients that have an isolated congenital aortic stenosis from 80 to 2016, 111 patients, median age 4 months, 31 neonates, repair with patches 52, without patches 59. Optimal outcome is no gradient. This band there, can you make it disappear? Optimal outcome is virtually no gradient and no regurgitation. So the suboptimal is okay. There is one early death, a patient who had arrhythmia, probably with a patch that might be involved in the coronary, left coronary occlusion, and one late death. Car accident. Sorry, this slide do not move. So the freedom from aortic valve replacement in that group is 60% at 15 years. And this is the freedom from reoperation. And you see the suboptimal group and the optimal group. You can see the result here for the freedom from reoperation at 10 years is very high. In that, this is a study between patients who had the tricuspid valve physiology and the one who have a bicuspid valve physiology. You can see that the bicuspid physiology gives much better long-term freedom from reoperation. That's with patch and no patch. Patch is in red, no patch in blue. 1 month old and neonates, greater than 1 month old and neonates, still a very nice freedom from reoperation. So by 10 years, half of the patients required a reoperation, but 2/3 were free from aortic valve replacement. Optimal intraoperative result associated with 80% freedom from reoperation at 10 years. Bicuspid physiology has a better freedom from reoperation. And the initial aortic valve repair, and which is what we aim for, delayed the Ross procedure as late as possible into adolescence or adulthood. The aortic endocarditis, 89 to 2000, 41 patients, 34 congenital aortic valve, previous aortic surgery 16. The operative mortality 0 out of 16 in repair. Ross procedure 2 deaths out of 13, homographs 3 deaths out of 9, and mechanical replacement 1 death out of 3rd. And this is the freedom from deaths and freedom from reoperation in these 3 categories. On the top of that, there was 3 mechanical valve replacement. The mitral valve, I shall talk about congenital mitral valve, rheumatic mitral valve, and endocarditis. Strategy is repair, always. Congenital mitral valve paradox. Small valves are very difficult to repair, but dangerous to replace. Large valves are very easy to repair, but never need to be replaced. When I say large, it is the annulus that allows an intra-annular position for the smallest mechanical prosthesis, so 18 to 19 millimeter. The operator's experience is important. So the threshold for surgery varies according to the size of annulus. If you have a very small annulus, a very small valve, you would try to delay the surgery as much as possible and see the patient's annulus grow. there is a recent evolution where there are some techniques described to replace the valve in small annuli. The melody valve, the other multiple techniques, very few cases, but that does not change the policy. So this was published in the GTC-VSC in 2006, and this is deaths in blue, reoperation in red, and replacement in yellow. Patient necessitating a re-repair. You can see the prognosis from re-repair is quite good. Another series from the unit is 2008-2014, congenital mitral valve 69, with 11 multiple left-sided obstruction, or so-called Schoen syndrome. 11 and 7 of them are less than 1 year of age, and 6 of them died. This is the survival curves. A group of patients that is interesting, but we don't have much time. But the rheumatic patients, we have in Australia, the Aboriginal patients, which have the highest incidence of rheumatic disease or rheumatic fever in the world. So we're very committed to this patient. We have 79 in that 20 years period, 79 patients, Aboriginal, all of them had a mitral valve repair. All of them had an annuloplasty of some kind. This is the correction of the type 3 at the bottom, and the next slide is the correction of the type 2 for the anterior leaflet mostly. Mortality is quite significant and due to recurrence of rheumatic fever, because of about half of these patients have less adherence to the antibiotic prophylaxis than you would like. Late reoperation, we re-repair on these valves. If they need a reoperation in adults, and most of the time they would have a mechanical valve, we re-repair, and you think that anything that suggesting that the valve is fibrotic would be a negative risk factor. If you have a large prolapse, it's a positive factor, protective factor. The valve failure is either replacement, death, or re-repair, or a significant regurgitation or stenosis. I can skip that. This is the endocarditis. This is very large repair after endocarditis, freedom from reoperation. I can't remember how many patients, but it is 50% at 15 years. Freedom from replacement, 70% at 15 years. This is the cleft, the regurgitation in left AV valve after the AV septal defect repair. The mechanism is always the same, whether you have had cleft closure or not. At the junction, at the tip of the junction between the superior bridging leaflet and inferior bridging leaflet, the tip of the valve is very sharp and does not have a big coaptation tissue. And in front of it, you have the left lateral leaflet that has a large coaptation tissue, but nothing in front of it. So you have a jet that is posterior. It's always the same mechanism when there is the normal anatomy. So you augment the cleft area with a patch that will go down into the inflow and suspended either to the paramedian chordae or you put artificial cords, and you have created a large coaptation surface in front of the left lateral leaflet. When there is a single papillary muscle anatomy, and then you have to preserve a bicuspid physiology, which is actually very stable. So you can suspend the edges of the cleft and increase the area of the leaflet tissue. Or you can use, at the beginning of our experience, we used a partial pulmonary homograft that worked very well, but do not age so well. Here you have the resuspension of the cleft. This is the partial mitral valve homograft. I would continue using the partial mitral valve homographs if we had the access to mitral valve homograft decellularized. We don't have that. I've been working with the bank, tissue bank in Victoria and in Sydney for years, and they're very slow. You have that in America, or you could have it in America. Anyway, these patients have virtually disappeared. We have very, very few of them now. So this is the patch in blue, the patch augmentation of the cleft with creation of a large, so there's 80% freedom of re-repair compared to this result with the other techniques. For the single papillary muscle, we have only 5 patients. One patient had a second repair, a third redo, and a valve replacement. 2 patients with partial mitral valve homografts had a valve replacement at second redo at 1 and 12 years later. All these patients that have had a mechanical valve inserted acquired an AV block. They were not done in our unit. In conclusion, repair, repair, and repair. Thank you.
Thank you, Dr. Brizard. Is there any time for the questions?
I think we are running quite significantly late. I think we
Okay.
just have to excuse.
Thank you.
this time.